everyone. Welcome to this webinar. So our webinar is about myeloma infection, clinical and life perspectives. It's organized by Myeloma Patients Europe. And why we are here today is because infection is such an important topic for people living in myeloma. It remains, unfortunately, a leading cause of illness and can be life-threatening. So we are organizing this webinar to inform you about infection risks with myeloma and myeloma treatments and about what to do about it while trying to have the best possible quality of life at the same time. So I'm Solène Claverel. I'm really pleased to be here. I'm Head of Medical Education and Scientific Engagement at MPE. I will be the moderator of this webinar, and thank you all for joining us today. I'll start with the agenda for today. So we'll start with a short introduction and housekeeping rules. Then our speaker, Jackie Quinn and Mimi Quinn, who are here with me, will give their presentations on myeloma and infections. Jackie will be presenting a clinical perspective from her experience as a myeloma clinical nurse specialist. And then we will hear from Mimi Quinn, to present her personal experiences with infections and infection management as a myeloma patient. We will then continue with a Q&A session before closing the webinar at 6 p.m. So first, I would like to give a short reminder about how to use the Zoom webinar app. You can use the question and answer feature, which is found on the toolbar at the bottom of the window. Please use it to ask questions to the panel. Click on the like button to upvote questions and let us know what questions are of high interest to you. If you can, please don't wait until the end of the presentations to ask your question, as we will try to group them by topic while the presentation is ongoing. Then we have the chat. Use it to chat with other participants, share your experiences or comments about the current discussions, or just say hi to your friends and community. If you are experiencing any technical issue, please let us know about it here in the chat, and one of my colleagues will assist you. Do not use the chat to ask questions to the presenters. Please use the Q&A feature for that purpose so we can see your questions. And last, I would like to inform you that this webinar is being recorded and will be available on our website, www.mpeurope.org, and on social media channels. So before we move to our speakers' presentations, I'd like to say a few words about new educational resources MPE has developed on the topic of infections. We have created 2 question and answers on the topic of infection risk with myeloma and myeloma treatments, and how to reduce infection risk in myeloma. So we also created 3 infographics that summarize in 1 or 2 illustrated pages the most important points raised in those 2 Q&As. And you can find all these on our website, download them or print them. You have a QR code here that will lead you on the page of our website where you can download those resources. Our colleague Adam just posted the links in the chat as well if you didn't get the time to flash the QR code. We hope you'll find them useful and that you will share them with your community, and we're also planning on translating them in several languages to better fit your needs. So now I would like to introduce our 2 speakers of the day, Jackie Quinn and Mimi Quinn. I'll start with Jackie. She's a myeloma clinical nurse specialist at the Belfast City Hospital in Northern Ireland. She's a registered nurse since 1990 with a lot of experience and qualifications in oncology nursing. Since 1998, she has specialized in hemato-oncology, working in the field of working in the ward and the day unit and hematology clinical trials as a clinical research nurse. She took up her current position as myeloma clinical nurse specialist in Belfast City Hospital in 2026. She later set up a nurse-led myeloma treatment clinic and prescribing for patients with myeloma and amyloidosis at all stages in their treatment pathway. She's part of several nurse and specialist networks at local and national levels. So we are very pleased to have her with us today. Mimi Quinn is a myeloma patient and registered nurse as well from Ireland. She's involved in the work of and activities of Myeloma Ireland. And she's the mother of 2 grown-up daughters and grandmother of 2 little boys. She has a very active lifestyle and enjoys a good social life. And despite her myeloma diagnosis, she continues to enjoy all her hobbies and maintains a pre-diagnosis lifestyle with some modifications that she will tell you about during her talk. So thank you so much to you two for being here today with us and for dedicating some of your time to MPE. So Jackie, the floor is yours for your presentation. Thank you.
Thank you for the invite to speak this afternoon. I'm delighted to join you. Next slide, please. The outline of what we're going to discuss this afternoon is a bit about what the immune system is, what is myeloma, how does myeloma impact on your immune system, how the treatments that we give you can reduce your immune system, common strategies that we introduce to you in the clinic and advice that we give you, and we're going to talk about some of the concerns that carers would mention whenever they're coming to clinic appointments with patients, and what does the clinical nurse specialist offer and how they can help you, and we will finish up with key takeaways. Next slide, please.
Jackie, before you start, can you please turn your camera on so we can all see you and enjoy your talk?
Apologies.
Great. Thank you so much. I'll let you continue. Thank you.
Okay, so what is your immune system? We bandy it about quite a bit, but what does it do? It's really made up of specialized cells and tissues and organs that really work together to protect your body from bacteria and viruses. We make plasma cells, which are a type of white blood cell, and these make antibodies. So you will have heard all of these terms used when you attend your hematology clinic appointments. What do antibodies do? Well, they help to kill off these viruses and bacteria that cause infection and help protect your body from exposure to these bacteria and viruses in the future. You will hear us mention helper T cells, and usually most people don't want to hear the detail of these. But when we're talking about T cells, I mean, you'll hear that mentioned whenever we talk about bispecific treatments and CAR T therapies. So they do fit into the picture, and these are white cells as well that help fight off infection whenever you are well and don't have a disease like myeloma. Next slide, please. So what is myeloma? We have to remember what it is. It's actually a cancer of the bone marrow plasma cells. And we've just mentioned these plasma cells are really important in protecting us and are a huge backbone of our immune system. So when you have myeloma, the body produces too many of these plasma cells. They're immature, so they don't do the job they're supposed to, which is to protect you from infection, be that viruses or bacteria. You will hear the mention of abnormal antibodies. So normal plasma cells will produce antibodies to protect you, but when you have myeloma, these antibodies are abnormal. You will hear them interchangeably called monoclonal immunoglobulins, M proteins or paraproteins. All of these terms, of course, are mentioned in clinic and can be quite confusing, but overall they mean the exact same thing. So it's important to bear that in mind. If you're producing these abnormal plasma cells, it can result in damage to some of your organs. Your kidneys can affect your bones and can cause damage to your immune system. So just remember and bear in mind that these plasma cells are abnormal. They're not working the way they should. They're not protecting your body from infection the way they should. I think it's important to mention too that myeloma is primarily a disease or a disorder that patients develop in older age, and the average age would be around 70. Now, there are caveats to that. There are much younger patients who come to the clinic with a diagnosis of myeloma as well. But we have to remember, as our body ages, we are more prone to an aging immune system, which doesn't function as well as it might have done when we were 20 years younger. So we have to bear that in mind as well. Next slide, please. So we do know from research that if you have myeloma, you are 7 times more likely to develop an infection. And that's for a number of different reasons. One is that suppression of your immune system, and that can be from the disease itself. And you have to remember the treatments that we are providing you with in clinics. There are many chemotherapy treatments. There are various combinations of isatuximab, daratumumab, lenalidomide, pomalidomide, which most patients will receive at some point in time, and all of those will suppress your immune system, as will the steroids, which are backbone of many of our therapies. And these also weaken the immune system. Whenever you come up to your clinic appointment or just before you start a new cycle of therapy, we will be taking blood tests. And one of the things that we look at are your white cell count. So we do create a bit of a fuss. So if you're speaking to your nurse, I will definitely involve in the conversation with patients what their white cell count is, what their neutrophil count is. Many of our treatments can reduce the neutrophil count in particular, which makes individuals very prone to very serious infections. So whenever your neutrophil count is really low, we don't want to start a new cycle of treatment, for example, because we will reduce that further and actually make you more susceptible to infection. We might give you supportive therapies like GCSF injections to boost your neutrophil count, because we do know if your neutrophil count is very low, not only can you get an infection, you can get life-threatening infections. So we do actually advise our patients very strongly, if they have any signs of infections, coughs, colds, temperatures, shivers, that it's really important that they contact their helpline and seek medical attention, and don't leave it, do it immediately. White blood cells are essential for fighting all infections. We also find that some of our patients can have other health issues, never mind their myeloma. They may have pre-existing problems with their kidneys, or that may be as a result of their myeloma. They also may have diabetes, and if we're given steroids, we can increase blood sugar levels and again increase that risk of infection. By the very nature of having myeloma, patients attend hospital appointments very regularly. And what do you meet in a hospital environment is folks who have infections or who are not well, and that can also increase your risk of developing an infection. Myeloma can also affect ability of some folks, depending on the treatment. They may not eat or be able to eat a normal diet the way they would normally. They may have difficulty in absorbing some of the nutrients from their diet, and that also can make an individual more susceptible to infection. We also use central lines in folks who have very poor venous access. We also give injections to administer drugs like daratumumab, Velcade treatments, and these injection sites can be sources of infection as well. And as I mentioned earlier, older patients can have a naturally weaker immune system and be more prone to infection. Next slide, please. I mentioned bispecific and CAR T therapies. These are new therapies, and many of you may have already heard of them or be on these treatments. These treatments are a new way of harnessing the immune system to fight myeloma. Bispecific T-cell engagers target 2 different antigens, one on the cancer cell and one on your T cell, and they redirect T cells to attack myeloma cells. So they're redirecting your immune system to fight off myeloma cells. And this can lead to T cell exhaustion, whereby your natural immune system is exhausted because it is fighting myeloma and can make you more predisposed to infection. CAR T cell therapies involve modifying your T cells to target myeloma cells, and it can then deplete your overall T cell population, which again can reduce your immune system. Next slide. There are many different types of infections that individuals may be exposed to or prone to. We can get bacterial infections, where you need an antibiotic. You can get a chest infection. You can get viral infections like flus, COVID. You can get fungal infections. You can get candidiasis, and you can also be very prone to what we call opportunistic infections. And these are infections that you normally wouldn't see, but because your immune system is low, you don't have any defenses, or your defenses are lowered, you can get infections that we mightn't see very often. So you'll hear us mention things like CMV, and we might mutter away that we're going to carry out additional tests. We take samples and swabs of everything. If anybody has a hint of anything different or new, or a cough or a cold or a skin lesion, we will swab, we will take samples, we will check infection markers. We'll do all of those things because we like to establish what exactly is causing a potential infection and treat it appropriately. Next slide. So what can we do to reduce your risk? Well, we give a lot of antibiotics, antiviral therapies. We can provide immunoglobulin infusions for certain individuals. I have mentioned giving GCSF, which are really white cell hormone injections, which boost your white cell count. And we can all patients who are on treatments will get a supportive care package, including many of these products. And it is really important, if you are provided with supportive medication, that you understand what we are giving it for and what we are trying to protect you from. And it is really essential that you realize we don't give these drugs for no reason. We give them for a very important reason, because we know, and research has proven, that if you take these and are compliant with the medication you're provided with, that it does give you a huge element of protection and reduces the risk of you developing a life-threatening infection, and very often reduces the possibility of you being admitted to hospital. We also recommend vaccinations, and that will be very much individualized to you yourself or your loved one. So if anyone is on a treatment regimen, it is important that they discuss with their healthcare professional what the recommended vaccinations should be. One thing I would say is to remember you should not have live vaccinations, because that can increase your risk of developing the disease. So things like COVID, including the booster vaccinations, are important. Influenza, pneumococcal, shingles. Timing is essential with these vaccinations. So as I said, please discuss with your healthcare professionals. If you're offered them by your primary care practice, or you have any questions, please discuss. Next slide. There are many things that you can actually do to help yourself. Simple things like washing your hands can be a lifesaver. Hand sanitizers. These are simple things that can be employed and significantly reduce your risk of infection. Regular showering. All of these will reduce any bacteria and reduce your risk of infection. I often get asked about wearing masks. If you are going into a very crowded area and there maybe is a lot of For example, at the moment here in Northern Ireland and Belfast, there is a huge rise in our COVID cases. So we were recommending that if our patients are going out into crowded areas, that they do wear a mask to offer them some protection. So it is worthwhile to bear that in mind. It can be helpful. Probably one of the most sensible options would be avoid folks who are sick. Ask your family and friends, please stay away if you've got coughs and sniffles. Reduce the opportunity of infections to be shared with you. Perhaps now coming into winter month, we're heading into flu season. Maybe this is the time to avoid big crowds. If you know of infections, as we do in Belfast, and we are recommending our patients are really careful and vigilant, be sensible. Practical advice can go a long way to protecting you. Think about how you prepare your food. Make sure food is cooked correctly. Simple things like washing fruit and vegetables can also reduce the risk of infection. If you're offered appointments and checkups for blood tests to monitor your blood counts, look at infection markers, please attend. Other health conditions that I've already mentioned, the likes of diabetes, please manage those appropriately. Again, they can reduce significantly your risk of infection. And I must emphasize it is really important that you seek medical attention if you're unwell. The number of our patients who will say, well, I've been sick now for a couple of days, but I didn't want to bother anyone. We really do want to be bothered. We want to hear if you're unwell, and we will then be able to advise you appropriately and try and avoid a serious infection that can be potentially life-threatening. Next slide. Carers can help as well reduce the risk of infection. Again, hand washing for them. And carers are very keen to know how they can help protect their loved one with myeloma. Simple things like hand washing, also being vaccinated with non-live vaccines, also protecting themselves that they're not bringing infection into the home. Sometimes carers are the best person to suggest to friends and family members maybe stay away if they have an infection themselves. Many carers like to be helpful and useful and try and do as best they can, and they can help with encouraging a nutritious, varied diet. It's important that they help to prompt their loved one to drink plenty and help with medication, because I've mentioned the supportive meds. These are huge in number and complexity, and trying to work out what to take and when, and carers can be essential in helping manage the medications and ensuring that you as a myeloma patient are taking these as you should. Again, from important folks in bringing and helping patients to attend their outpatient appointments. And sometimes when our patients have infections, they're maybe not so aware that they are unwell themselves, but their family members are there. They're an extra set of eyes, and they can be vigilant, and they can pick up signs of infection and help seek medical attention in an appropriate time frame. Next slide. So what do nurses like myself do? We try our best to educate patients a bit about their disease and about the specific treatment regimen that they may be on and the complications and side effects that would be associated with it. There's some of our treatments, the patients are more prone to serious infection and low blood counts, and we can help advise you about your regimen of treatment and the risk that it poses to you in terms of infection. And we will inform you about your white cell count, your neutrophil count. We will check infection markers. We will take samples, and we will advise you about the supportive medication. And if we have to do that every week and repeat that information, we're more than happy to do so. And you can then ring in between appointments if you have any questions or queries, or something isn't terribly clear to you. You can ring your nurse specialist and have a conversation about that with her or him. We can also advise you, the individual, about the appropriate time to have your vaccinations. It's not always the best time. If you're in the middle of a cycle of treatment, it might not be appropriate at that point in time to have a vaccination. You may have an infection already, an underlying one, that it might not be appropriate to vaccinate at that particular time. We can also advise you on all the different signs and symptoms of infection and things to look out for. We can advise you on lifestyle modifications. For example, folks are maybe looking after grandchildren. Your grandchildren may be having their childhood vaccinations. Is it appropriate for you to be looking after them at that particular point in time if they're having live vaccines and you're on treatment? We can give you advice in and around your own circumstances. Some of our patients like to go on holidays. Again, do you need any particular vaccinations, or are there any particular risks to the destination that you're going to? And again, we can have those conversations. We can advise you on what support resources are available. We can give you written information. We can direct you to the appropriate team for your vaccinations or advice, and we will also then schedule and coordinate your follow-up care as well. Next slide. So the key takeaways from my talk would be: infection is a leading cause of serious illness and death in patients with myeloma because of the cumulative effect of the disease, the treatment, and your individual patient factors. But on a very positive point, if you follow advice and prevent infections, you can significantly reduce those risks and lead a very good quality of life and be very well. But it is really important to take advice. The periods where you're more at risk of developing infection are in that first 3 months after diagnosis, and whenever your myeloma is just relapsed or becomes refractory or not responding to your current therapy. So there is the ability to develop a protective response after your vaccinations. Really depends on your individual factors. So it is really important to remember you're an individual and your circumstances are unique to you. And it is really important to have a conversation with your healthcare professional about your circumstances, particularly in and around whenever you're offered vaccinations. And these may be variable depending on which country you live in. Any concerns, your healthcare providers are more than happy to hear about and more than happy to discuss with you. And please, if you take away nothing else, seek medical attention if you're unwell or have any symptoms of infection. Thank you.
Thank you, Jackie. Thank you. It was very comprehensive. So thanks for sharing your clinical perspectives and giving all those recommendations. So I would like to now invite Mimi Quinn to share with our audience her experience with infection as a myeloma patient. So Mimi, the floor is yours. Make sure you turn your camera on and your microphone on.
Okay, hi. Can you all hear me?
Yes.
Okay. First of all, I have to apologize for this. I have two screens in front of me, so I'm looking at one and reading notes off another. So sorry for the side profile, you'll see.
You'll be great, don't worry.
This is my first time doing anything like this, so I'm very nervous. So yeah, as Celine said, my name is Mimi. Also Quinn, would you believe? Both myself and Jackie have the same surname. We're not related, and we're from different parts of Ireland. Jackie's from the north and I'm from the south. So Jackie's speech, like Celine said, was very comprehensive. It actually leaves me very little to say, so I'll just tell you my story. Next slide. So I'm just going to talk about my myeloma battle through these headings. Next slide. So I was diagnosed in 2023, and I'm just about 1 year after my stem cell transplant. From the beginning of my journey, infection was the thing that raised concern for me. I was working as a nurse. I had 2 jobs, all during COVID, and I suppose alarm bells should have been ringing, because between 21, 22 and 23, I had about 18 PCR tests. That's the COVID tests, because I was getting such frequent infections. And at the time, everybody excused and said, oh, well, everyone's getting infections. But during 2023, my infections were prolonged and very pronounced. And where everybody else would be better in 2 or 3 days, my infections went on for a couple of months. I did notice some increased fatigue, but I'm a menopausal woman and we all complain about fatigue. And like I said, I had 2 jobs. I was a very busy person. And I also loved to train and work out. So I had coincidental hip pain, which thankfully turned out to be just coincidental. So I did notice after a routine blood test that I had a change in my blood profile. So while the doctors who were looking at because we must remember that back then we saw different doctors. Our health systems were topsy-turvy, and I felt that anytime I did seek medical help, I saw a different doctor every time. So I noticed myself that there was a change in my blood profile, which I raised concern about, and that was kind of seen as well a post-viral response, and it would take time for my bone marrow to recover, and I was relieved and consoled by that. By September of 2023, August, I really just insisted on a hematology consult. And at the day I went for my hematology consult, my consultant told me that during some of the blood tests that he ordered, that I had a very small protein, and that he diagnosed MGUS there on that day. But because I had a pain in my hip, he actually went ahead and did a full myeloma screen, and the results 3 weeks later showed that I had 80% plasma cells in my bone marrow, and I was diagnosed with the stage 1 standard risk IgA lambda myeloma. So that was quite a shock. Even being told I had MGUS was a shock, but being told 3 weeks later that it actually was fully blown active myeloma. So 2 weeks later, I started quad therapy with Dara, thalidomide, Velcade and Dex. I had my stem cell transplant, like I said, 1 year ago, and I had consolidation of 2 cycles of the same treatment, and I chose to go on the Majestic 4 trial, which is ongoing in Ireland at the moment, or around Europe at the moment, for my maintenance. From an infection point of view, I had, once I was diagnosed and started treatment, I did get a lot of infections, but they never became as bad as the infections I had before I was diagnosed, because they were monitored. I was being observed, my bloods were being done, I was getting GCSF when I needed, when I was neutropenic, and eventually I had a few infusions of IgIV at that stage. Next slide, please. So Jackie has done this so well. I feel that these slides are a bit redundant. And I think as a myeloma patient, we hear this and we get information from so many people. And information is readily available, both from our professionals, and be very careful where you're getting the information from. But I thought after I made this slide that I should have made circles like the Olympic flag, because all of these individual elements, when you're looking after your care, when you have myeloma should be interlinked, because when one is not being dealt with properly, it has a cumulative effect on all the others. So for instance, if I don't take protective measures, I pick up an infection, and when I have an infection, I don't eat very well. And when I'm not eating, I'm probably not drinking enough. I get a little bit dehydrated. Then I get constipation and I get fatigue. Skin care is a big problem for me. I'm on lenalidomide, and it makes my skin very itchy and dry. So all of these things have a knock-on effect of each other. So the importance of a routine for me, and trying to, when you're doing one thing very well, it has a knock-on effect on the others. Next slide, please. So I chose to go on the Majestic 4 trial because I am absolutely passionate about research and clinical trials. And from the very beginning of my myeloma experience, I went out of my way to find good, solid information. And I read up every trial I could find. I knew them all. I knew who the principal investigators on the trials were. And that gave me great consolation, because when I started working as a nurse 30 years ago, I looked after myeloma patients and they did not survive for very long. So when I was reading trials that had a projected progression-free survival of 17 years, or that how fast drugs were coming onto the market, and how they were finding new markers that they could access on the myeloma cells that they could use as a target for different molecules, I was so happy and, like I said, consoled by that. So the Majestic 4 trial is a trial that's investigating the use of a BCMA, bispecific antibody, and being on the Majestic 4 trial, I was randomized to standard of care. So I actually am not getting a bispecific, I'm getting just lenalidomide. So while I'm on that trial, I'm getting monthly blood tests. I get a bone marrow biopsy done every 6 months, and I get a whole body low dose CT scan once a year. I take lenalidomide 15 milligrams daily. So I don't get a break off that. And yeah, it's tough. I'm finding that a little bit tough. I notice that I am a lot more fatigued. Because I have such frequent infections, I get monthly IVIG now. And while I still pick up the infections, I definitely think that this has lessened the severity of the infections for me. I do take all of the protective meds that Jackie referred to. And I also am up to date with seasonal vaccinations. The other things that I keep up to date with is mammograms, smears, colonoscopies, all of those things that will give you indications of other illnesses that may be evolving, or I make sure that my blood pressure and everything is all right, get my cholesterol checked so that there's no chronic disease processes happening. I have enough to deal with. The last 3 points here I will put into one. Obviously, we're looking at temperatures and I'm observing yourself very closely for any sign of infection. And I seek medical advice. But I found, for me, I was getting a lot of different, I won't say types of advice, because the advice is consistent. It's just how some people deliver the advice. Some people will say, oh yeah, no, your neutrophils are 1, I'm not too worried about that. And somebody will say, neutrophils of 1, you need to isolate. So I just found one voice that I trust, one voice that understands my lifestyle and me as a person, and what is realistic and achievable for me. Next slide, please. So look, I use this slide because I wanted to give everybody just a little idea of balance for me. Okay, so you might see this picture of the seaside. That's close to my house and my favorite spot. And I spent a lot of time over there by myself when I was diagnosed, swimming and sometimes just shouting into the wind all my fears and my anxieties and my anger about what was happening to me. The next thing that my dog, this is him, this is Marley. and he's my constant companion. And for me, he's the epitome of mindfulness. He lives in the moment. He doesn't think about the future, and he carries no regrets about the past. And he's carefree, and cancer took that carefreeness from me. So while I'm with him and I'm out there on the beach and I'm in my kayak and doing my stuff, I get a little bit of that carefreeness back, and myeloma takes a back seat. And the fear of infection and the fear of all that just is put away for a little while. And in the middle is myself and my sister-in-law Lorraine, and we, a group of friends, took part in a 21-kilometer hike a couple of weeks ago, and it took me about 4 or 5 days to get all my circles working again because I was so tired, but it was great. It was great, a sense of achievement, and I really felt that I had taken control back from cancer just for that day at least. Next slide, please. So I decided to go back to work. I went back to work in May. And again, I work as a nurse, so I'm meeting a lot of people with infection. We're surrounded by infections, both acute infections, chronic infections, and hospital-acquired infections. So going back to work as a nurse was it took a little bit of planning and care. I had always thought that once I'm 57 now, and I thought that coming up to this age I would start thinking about retirement. But when the decision was taken away from me, I actually resented that and realized that it was a large part of my identity. Not having an income while I was being treated for cancer took my confidence, took my independence, and took part of my identity as well. And I did not like and didn't go easily into being cared for. I was used to being the carer, I was used to being strong, and I didn't like that because I felt quite well the whole time. I wanted to stay connected with the people and the job and the routine that I know and love for the last 34 years. Actually, I didn't realize how much I loved it until I had to stop it. So my employers have been very supporting, and so has my team. And once my immune system had stabilized, we negotiated and put some protective strategies in place. So I have gone back to work on a 2-day week at the moment, and I will increase that in October to 3 days and see how I get on. I'm very lucky because I can actually control who I meet. I do phone triage quite a lot, so I know I have a report on every patient. So I know what infections that they have, I know what I'm dealing with, and I can take the appropriate precautions before they come in and after they leave. I feel that it's so controlled at work with the PPE and stuff that we can use there, that the supermarket is nearly a bigger risk for me than being at work in the clinical environment as a nurse. Next slide, please. So with regards to mental health and resilience and motivation, I've already alluded to this a few times in other slides, that cancer took a lot from me, and it took independence, and it took it, but it gave back a lot as well. And I often wonder, why does it take a cancer diagnosis to make us realize how much we love and how much we are loved? And what wonderful people and friends we're surrounded with. I have a powerful family who I'm forever grateful for everything they do. While I was on treatment, we did some fundraising, and my family became the Laughing Army, is what they called us, because they were so powerful. Asking for help was something I found difficult, as I've said. I was used to being the one that people came to for solutions and people came to for help. I was used to organizing care. I'm not an organized person in my daily life, but so I found that difficult. So what cancer has brought is that I can ask for help when I need it, and I can say no when I need to say no as well. If things are too much, or I feel I'm particularly fatigued, or if I feel that there's an infection risk that I'm not willing to take, then I've got that strength, I suppose, that I never did have before. Setting goals and challenges are really important, but I don't think the goals need to be over the top. I mean, when we have cancer and you're in remission and you've so much to deal with and you've so much to be afraid of, setting a goal and achieving it can be fantastic. But it doesn't need to be extreme. It can be just, your goal can be just enjoying every day, enjoying your friends, enjoying your family, just going for your simple walk. It doesn't have to be anything too extreme. Support groups and cancer buddies. So my daughter has used this term, cancer buddies, and she says, are you going off to your cancer club now? So support groups have been immense for me, both, and I've met some fantastic people, and myeloma patients themselves can give you a consolation and an understanding that nobody can get. And I think that me as a cancer patient, a myeloma patient, that I have a level of understanding now in what I do at work, and I can share on a more effective level as well from what I used to do before, when I didn't really understand what it's like to take 40 milligrams of dexamethasone, or what it's like to live and know that your neutrophils are only 0.5. So yeah, it's given an awful lot, and I've got amazing, like I said, role models. My advice to anyone starting is find a role model that you can identify with, somebody who's realistic and for you in your life. And again, healthcare professionals, I'm so proud of the profession that I'm in, because the nurses and doctors I have met throughout this, like I said, it's made me proud of what I did as a career, when I see the help and the support that nurses and doctors can give us. Okay, next slide, please. So my key takeaways is just managing myeloma is not about avoiding life. When you're trying to manage and live a full life, it's about adapting. It's about being aware of risk, managing side effects, emotions, expectations, and doing that while incorporating it into your daily life, remaining happy and optimistic. I mean, there's so much to be optimistic about. We were at the EHA conference, my MPE advocacy group that I started, and that's one of my challenges as well. I challenged myself to become more informed, and that has been amazing. And we had a great time, and I think we all left there feeling more optimistic about what was happening in the myeloma world and what was ahead. Managing infection risks, we can do our best, but if managing infection for me becomes too restrictive, then my lifestyle doesn't flow like I want it to flow. And it's very important for me to have a bit of excitement and a bit of adventure in my life. So again, risk assessment all the time is really important for me. I have I have two beautiful grandchildren, but the youngest one always seems to have a cold, and we call him patient zero, because every time I'm with him, I end up with a cold. But his goes away in 3 days, mine lasts for 2 weeks. So we learn to live life. I'm never going to be in a situation where I don't see him. If he's a temperature, I don't see him. If it's just a little cold, I do. So we learn to live life with balancing risk. Getting back to work has given me control back. It's control that I had lost for a little while, and I love that I'm giving care now rather than receiving care. And even though I appreciate all of the care that I got, like I said, I'm enjoying being back at work. And then the last thing I have to say is self-advocacy. I do believe that all of the information I've garnered and all of the education the clinical trials that I've looked at, the people I've spoken to, the information I've gathered has given me a strength. It's improved my communication, and it allows me to partake in every single chance I get to have to partake in shared decision making. And that asking questions, and like I said, I have had the skills to find one voice that I trust and move forward. So balance is possible with planning, teamwork, and self-care and self-awareness. So I think that's all I have to say now.
Thank you so much, Mimi.
Yeah.
It was great to hear your experience. I would like now to move to our question and answer session. So please, if you haven't done so, ask your questions using the Q&A feature and vote for the ones you would like us to answer in priority. So while you think of those questions, please let me remind you of where to find our educational resources on our website. So please scan the QR code or click on the link that we've posted on the chat. So now we can stop sharing screen, and Jackie, I will ask you to come back so everyone can see you during the Q&A. We have a first question about supplements. Do you know if supplements can help myeloma patients to fight off infections? I guess, Jackie, that question is for you.
I suppose you have to be careful about supplements. It would be, sometimes they can be useful, particularly if you're finding that your levels in a particular nutrient are low. So it's definitely worth having a chat with your healthcare professional. It also would be important to know what treatment that you're on, because there can be interactions, or the interactions can be unknown. So it is very much something to discuss with your doctor or nurse before you decide to take any supplements, because everybody is going to be very much an individual case, and you don't want to run the risks of drug interactions or taking a supplement that's completely unnecessary for you.
Thank you. We have a question that is very case specific. Basically, we have a situation where infections are handled with GPs, but then it gets tricky to get followed up or treated during the weekend. So what blood tests make sense in case someone has a fever? How would people know whether it's viral or bacterial, or can they even know or find out? And then what would be the medication strategy in that case?
I think again that if anyone has a temperature or any signs of infection, it again is very individualized, because everybody will be on different treatment regimens, or you may not be in treatment at all. I have to say every centre and probably every region will have their own way of managing and have particular advice specific to their area. I know that from our point of view that we do have a designated helpline that we encourage all our patients to ring if they have any signs or symptoms of infection, and they're triaged. So they would be asked a series of questions and be directed to the most appropriate place for managing that particular infection and those individual circumstances. So it depends on what's the actual pathway is in your area, and it is really important to be familiar with that and to follow that to the letter. So it may be that, we would not direct someone to a GP unless we had triaged them first and deemed that it was a simple infection that would be easily treated and maybe bacterial. But again, very much dependent on the treatment regimen that they're on at the moment, and what their most recent blood counts are. So you need a full picture, and you need someone who knows your individual case and knows what your blood counts, etc. are like. So
So
you would
they
need
would
to follow
need to ask their hematologist what's the path to follow in the specific country or the specific area where
because
they're
it can
living.
be so variable.
For me, that was difficult, because as a nurse, I learned for years about overuse of antibiotics, and then I became a myeloma patient. And every time I went to a doctor with what I suspected was probably virus, I was on antibiotics. So that's what I was talking about communication and having one voice, finding one voice and one management system, being clear about what pathway you need to be on when you do have a symptom. Because, a lot of the GPs don't understand even where you are in your treatment. They don't understand
Exactly.
the drugs, and they don't have access to blood results. So I would ask for I ask personally for what do I do on a Saturday night at 12 o'clock, and I know what to do and who to call if it's a thing I feel I have an infection that warrants, if my temperature's up and I feel very unwell. Yeah. And since I've started doing that, I've avoided so many antibiotics, because most of what I've had, luckily, has been like viral infections.
Yeah.
Thank you. Jackie, you talked about immunoglobulin replacement therapies. Maybe you could elaborate a little bit more for us what they are, how they are given, and how often should one be treated?
Again, that's very much for individuals. For someone who has recurrent infections, that actually stops them having their treatment delivered on time. So in those cases, we would look at what their immune system looks like and what their immunoglobulin levels are like. And we would then start them on replacement therapy, which can be intravenous, which we use here. In some centres, you can get subcutaneous injections of immunoglobulin. In this centre as well, we would also offer immunoglobulin to patients who are receiving bispecific therapy or CAR T therapies. Particularly here in Belfast, we're not a CAR T centre, so we would have patients on bispecifics, and every single patient would be on immunoglobulin. So those are infusions that are given usually once per month, and we then would monitor their immunoglobulin levels, and we'd also monitor each individual for any incidents of infection. But it is definitely a really good way of reducing the risk of infection and reducing the numbers of infection, and has been proven to do so.
Thank you. Is there anything else then that you do in your center that would be specific to bispecifics in terms of infection risk and prevention?
We are very vigilant in those individuals that are receiving bispecific therapies. We would do an awful lot of work with patients to educate them, make them very aware that, you can get symptoms that are maybe just a little bit different from you, but it can be a sign of opportunistic infections. So we're seeing things like CMV incidents rising, weird infections that you wouldn't necessarily see routinely in patients coming through the haematology centre. So we're vigilant. Any new symptoms are investigated thoroughly. We get to the bottom of, if there's any change in bowel habit, if patients have diarrhea, if they've got a cough, we get samples. We go after any symptom just to exclude infection. And we make sure patients are really well versed in, if you are unwell or something is different for you, ring us. If you're very fatigued or it's a vague symptom, you maybe have a low temperature, maybe not high temperature at all, maybe just are nauseated, anything different, we are very vigilant about going after those for potential infections. And to be honest, it does work very well. We are keeping our patients out of hospital. We're keeping them very well. We're working together to reduce the risk of infection.
Thank you. Are there any additional measures that are taken by hospitals to protect patients coming to the hospital, like in terms of which parts of the hospital patients go to, which people they meet, to protect them against infection? Maybe there are some telemedicine processes that are put in place. Do you have any experience with that?
Yeah, well, we have our helpline. So if anyone's unwell, we would encourage them to ring. Mm-hmm. And if they have any symptoms suggestive of infection, they are directed away from the main thoroughfare of exposing if they have an infection, exposing the other patients to it. So we would be quite vigilant about that. We're very vigilant about informing patients, if you're coming to a clinic appointment, you're unwell, ring the helpline. And again, we redirect anybody with an obvious infection away from our patients who are attending clinics or our day unit in particular. And we screen our patients that are being admitted to our haematology wards before they're admitted. You would be isolated if you had a particular infection, and it's to protect both yourself and the other patients in the ward. Nursing staff, we have infection protection measures in place. So bare below the elbow, strict hand washing, PPE, protective equipment. Again, all to protect our patients from the spread within the clinical environment. So we are quite particular about it. And, we do work very well, and we do screen a lot.
Thank you. No, that's good to hear. We are reaching the end of our webinar, so I would like to thank you both for being with us today, for sharing your experience, sharing your knowledge, and I know we didn't get the time to answer all questions, but I hope our educational materials may help our audience understand some of the topics further. And I would like to thank you to thank our audience for being there today to listen to you, Mimi and Jackie. Thanks, Mimi and Jackie, again. And on behalf of MPE, I wish everyone a very pleasant evening.
Thank you.
Okay, thanks.
Bye, everyone.
Bye-bye.
Bye.